Welcome to Proposers Day for the Upgrade Program, or Universal Patching and Remediation for Autonomous Defense. Appreciate everyone coming today and your interest in the program. I'm Andrew Carney. I'm the PM for this effort. Today, we're going to start with a bit of an overview of ARPA-H as an agency and Resilient Systems Office that I'm a part of. Then we'll go into details on the Upgrade Program. We have a guest speaker from one of our HHS partners in Asper. And then we'll get into some of the contractual details about the solicitation. And then we'll end with some of the questions and answers that have been submitted and that we've been talking about with regards to the draft solicitation that you've reviewed. And then for the rest of the day, we will have sidebars with folks. I know we weren't able to schedule everyone that requested one. Apologies, it was first come, first served. But we're looking forward to talking to as many people as possible today. ARPA-H, the Advanced Research Projects Agency for Health. Our mission as an agency is to accelerate better health outcomes for everyone. The remit here is broad and enables us to consider and tackle problems across the spectrum of healthcare challenges in the United States. ARPA-H is a funding agency. We do not have our own labs. We do not have our own researchers directly. We identify problems and can craft research programs around them, and then fund you folks, work with partners across other federal agencies and state collaborators, as well as industry and academia, to tackle the problems that we've identified as sufficiently hard, ARPA hard, if you will, that we'd like to address. We are not focused on any specific disease or condition, and we do not fund grants. These are some of the differences between the NIH centers and ARPA-H. We fund outcome-based contracts. And so we want to be able to identify milestones and deliverables that will help us identify successful research along the path of these multi-year contracts. If you haven't worked with an ARPA, there are multiple ARPAs in the federal government, agencies that are that promote autonomy amongst the program managers and the offices to identify problems independently and then create the frameworks to address them, which are then sort of approved by leadership but not directed. So it gives us a lot of flexibility in how we address these issues. It gives us flexibility in the performer communities that we engage outside of traditional sort of venture capital or academia. And there's a sense of urgency across the agency. Our leadership and our program managers are all term limited. So we rotate through, we're given an initial term of 3 years. We can receive an extension, but ultimately we have a ticking clock that starts on our first day. And this creates a strong incentive for us to move as quickly as possible, given the unique and fantastic opportunity that sort of working in one of these agencies and working at ARPA-H is. We're also able to hire. We have unique hiring authorities that enable us to hire folks from across different levels of industry and provide appropriate compensation. The level of autonomy that PMs that we're provided, that our office directors are provided, is very high. And so this enables us to think creatively about potential problems, and then to also empower the performers to also think very creatively and really think of ways to address these problems that just aren't otherwise possible. Or that's another way of saying we're a very problem-focused organization. We want to identify problems and solve them. And once we've solved one, move on to the next. We are focused on every part of the healthcare ecosystem. This includes thinking about not just patients as customers, but also thinking about providers, thinking about healthcare institutions, thinking about the pain points that people are experiencing at every level of our healthcare ecosystem, and then how we can leverage performer communities and work with other stakeholders to address them. So once again, a lot of flexibility, a lot of creative problem solving is the name of the game. And it's very rewarding both to sort of be able to identify solutions that didn't fit in existing swim lanes and then help cultivate them and bring them to fruition. And it's also very exciting to work with existing federal partners to sort of maybe help realize ideas that may not be possible in existing frameworks. Where we can leverage our flexibility on their behalf to do great things. ARPA-H is an agency, are split into multiple offices. We have Health Science Futures, Scalable Solutions, Proactive Health, Resilient Systems, and the Project Accelerator and Transition Innovation Office, or PATIA. I'm part of the Resilient Systems Office. Each of the offices focuses on different elements of improving the nation's healthcare. In Resilient Systems, we're really focused on building integrated anti-fragile systems that are able to deal with the wide array of sort of challenges that we're encountering as both the technology that we use for healthcare evolves and also people's needs. So how do we make sure that these systems can handle today's issues, the anticipated future issues, and make sure that there's high availability sort of our healthcare resources to the population as a whole. When we talk about PMs, or program managers, and programs, and we talk about this ticking clock or the timeframes, as I said earlier, PMs are initially appointed for a 3-year term. ARPA-H is a relatively new agency. We haven't had the opportunity to extend any PMs yet. So everyone's still in their first term. But this also promotes dynamism within the agency. We want new ideas. We want new people, new perspectives. And similarly, programs have a fixed lifespan, 2 to 4 years generally, and then potential consideration depending on their success for maybe a transition tail. But once again, a limited window to achieve a goal. And so it's a good way of gelling kind of everyone together, both in the performer space and with our transition partners and customers. We're all cognizant of the fact that we have this limited window to perform in. And today's programs will help seed the field for tomorrow's, right? We build on the existing portfolio and as it evolves. And so it's really exciting to be part of the kind of inaugural set of program managers of the agency, see our first sets of programs evolve, and then think about what's going to come next. The program lifecycle, how we actually determine and develop the programs, isn't something that a lot of folks necessarily have exposure to, but we spend a lot of time, months and months and months of stakeholder outreach and research characterizing the problems that we're interested in tackling. If you're familiar with DARPA work, the Heilmeyer framework is a series of questions that help to characterize and explain why a problem is worth addressing. And then also talking to the stakeholders in the space that we are working in, having a good sense for not only what the problem is, but also how does the solution need to be shaped to fit into sort of the current reality of the stakeholder. As a part of designing the problem, we also look to energize the performer communities and potentially bring together different disciplines and communities that may not work together frequently, and sort of create these interdisciplinary teams that then create or encourage interdisciplinary work to create these kind of new creative solutions and ideas, regardless of where they're coming from. So, empowering folks to work across whatever silos they normally kind of live in. And then once we've selected and funded the performers, it's up to the program manager and their team to help actively manage the effort. So in addition to the milestones or deliverables that were defined as contractually, there's this constant sense of sort of like, how do we push, if you're being successful, how do we push you to try more, to do more? If you're struggling, how do we help redirect? How do we help pivot if there is a pivot to address the problem, and or how do we leverage additional resources if required? And so that sort of, as we work with our performers, both internal to programs and across the agency, we're able to capture and share a lot of insights. And there's a lot of focus on sort of intellectual honesty, technical honesty. Like, we want people to share things that don't work, right? We want, trying something is interesting regardless of the outcome. And that's something that previously, when I was at DARPA, I really enjoyed kind of working with different performer communities and hearing lessons shared, things that didn't make it into papers, didn't make it into reports. But honestly, like, the way that we were able to navigate the state space for large complex problems was very dependent on our ability to identify, dead ends or things that weren't behind. So definitely encourage both anyone interested in performing an upgrade or other ARPA-H work to really consider, like, being kind of failure forward. Share those with your peers. Yeah, could lead to some super interesting discussions. And then as programs develop solutions and successes, then the discussion on long-term sustainment kind of ramps up. And we try to identify, where does this technology, where should it live long term? ARPA-H funding is not permanent or not. So once we've developed the proof of concept, once we've proven the technology or the idea, how do we find a sustainable way for it to live, either industry or academia, or potential sustainment from another government agency? That's a very solution-specific discussion, but that can involve mentorship for startups. That can involve assistance with talking to different flavors of potential investment, and assistance with licensing that ensures the technology, that your IP is safe, and also that the technology, the great things that you've developed, are accessible and fit within the frameworks that we need them to benefit everyone, right? Better health outcomes for everyone. And that is the agency. I realized I sort of didn't really introduce myself. I know some of you on the call, maybe a good number of you, we've worked together over the last 2 decades. But my name is Carney, and I have spent a lot of my career focused on offensive flavor security, a lot of software and hardware analysis, focused on how we identify flaws in systems, and then and coming to ARPA-H has been about taking that experience and expertise and figuring out how to fix and build them better moving forward. And so a big part of Upgrade was inspired by thinking about the threats in a very detailed way, and then thinking further about how we can empower our defenders, our IT teams in healthcare, to deal with these sophisticated, kind of well-resourced attack campaigns. And that's one of the driving thoughts behind creating Upgrade. So the question at the heart of Upgrade is, what if every hospital could autonomously protect itself and patients from cyber threats? Today, we see consistently in the news reports of our healthcare systems being attacked, being held for ransom, effectively being their care being denied to vulnerable populations. And we've seen these attacks rise over the last few years. We've seen the severity increase, and there are a lot of folks working on solutions in this space. And I think Upgrade hopefully will address a gap that helps reduce the frequency and intensity of these attacks if we're successful. But the impact of these attacks is significant. We're seeing approximately half of hospital system downtime attributed to some flavor of cyber issue or attack in the last decade. We've seen tens of billions of dollars of care denied, of people unable to receive care because of these incidents since 2016. And we've also seen an increase in the number of public proof of concept exploits for healthcare technology. This is a threat that is growing. And the ecosystem here, from a defender's point of view, is challenging. We have lots of technology where extending the life, using it for as long as possible, is very advantageous from a care providing standpoint. The longer that we can use the devices, the longer that we can use the hardware, the more care we can ultimately provide. And even just day over day, availability of this technology, availability of these devices is a primary concern of healthcare providers. So even downtime to patch, the risks involved, the accepting the cost of downtime is itself challenging, even while these same devices have known critical vulnerabilities. And so this has produced a scenario where, as a sector, we see patching. It takes a long time to patch devices in healthcare environments. Applying these updates can take over a year, which relative to other critical infrastructure sectors, it's a very long time, the slowest, in fact. And it's possible, these patches may prevent harm just through their application that we know to be preventable. And the environment, the teams themselves are under-resourced, understaffed, especially given the complexity of the environment they deal with. And so, these are all challenges that the Upgrade is looking to improve the situation for. We can reduce the number of attacks, we can increase the rate at which we patch, and the overall security of our hospitals, our healthcare ecosystem. So digging into that a little bit more, there is a fundamental asymmetry to sort of cyber conflict, where attackers only need to penetrate defenses. They only need to sort of get through a layer of defense once. And then typically they have the ability to propagate, and they've escalated their ability to have negative impact on the system and can continue to do that sort of at every layer. Whereas defenders must be correct every time. So even in a resource-rich environment, this asymmetry is problematic. In a resource-constrained environment, this asymmetry is brutal. So thinking about hospitals as just a technology ecosystem and hundreds of potential vendors across the nation, different software versions, different configurations of networks. We have 6,000 hospitals and clinics across the country, and each one of them has a relatively unique configuration with different vendors in their own personal ecosystem. And at the same time, most of the technologies that we rely on to reason over and defend these environments are focused on the traditional, the commodity compute, right? Your desktops, your laptops. If you have on-prem servers, those servers, your mobile devices. That's where the bulk of our investment, sort of as a technology sector, when we think about virtualization or automated vulnerability discovery, most of that technology lives on the platforms that are most common to us. But in healthcare, in hospitals, most of the devices are not covered by those technologies. And so we have technologies largely developed for enterprises that have homogeneous compute environments where configuration management is still a challenge, but manageable. And then these technologies are adapted into a space with orders of magnitude more complexity, a very different calculus on availability and connectivity between these devices, and also a lot of sensitive information. Protecting patient data is further complicated by the fact that the ecosystem is complex, and the devices producing the data about patients or that require access to it are in this vendor ecosystem that is not necessarily addressed by enterprise kind of grade tools. I actually started when I was in grad school. I was system administrator. I was the sole on-site sysadmin for had a few hundred machines, tens of server racks in my domain, and it was still challenging. I automated a lot of pieces of my own work, but I still had to deal with a number of different tools. I did not keeping things that was challenging. Talking to healthcare IT folks that work in this space, both at smaller facilities and larger ones. This challenge is considerable and I think very hard to deal with the current landscape of available solutions. Not for lack of trying, by the way. There are solutions that have attempted to tackle pieces of the space. But I think the challenge merits larger investment and some creative problem solving discussed earlier. So upgrade. One of the core ideas with upgrade is that we can create a nexus of both information and orchestration for this environment, a vulnerability mitigation platform, if you will, that can help manage both the devices in a network and reason over them, but also help manage and use the tools that have already been deployed. We're not looking to replace effective tools in this space, but because these tools tend to address portions of the overall problem, there's a need for an ability to meet IT teams where they are, help manage the technology they have chosen as the best tools for them to do what they need to do, and then augment that and add to it with additional technology that we will develop on the program. We want to be able to accelerate the rate at which we sort of modify and actively manage hospital equipment and healthcare IT environments. And a big part of that is better understanding of the environment, reasoning over it more effectively, more quickly. Because if we understand the environment, we can make more informed decisions, and we'll also have a better sense for the context that a very specific configuration or facility may make or have, rather than more generalized guidance or adapting, enterprise best practices to these very specific complex environments. And so there are four major components of upgrade. Starting in the lower right-hand corner, this nexus, this vulnerability mitigation platform, our ability to deploy and interact with the environment is key. And then moving up, we need to be able to make high assurance decisions about the devices in the environment. And so we need to be able to understand both at a device and application level, but then at a system level as well, what's going on. Once we have the ability to reason over the system in greater detail, we can then start looking for issues proactively. We can find vulnerabilities latent in the systems before they're exploited, before they become an issue. And then we can automatically develop some flavor of remediation or recommend some fix via the vulnerability mitigation platform that addresses that vulnerability. And having that whole process creates a rich set of information about both the system, the impact of the potential vulnerability, and then the cost or the impact of the fix as well. And so in terms of technical areas, the way that we're dividing the program up, we have the vulnerability mitigation platform, that nexus between the technology and managing the actual healthcare technology environment. TA2, we will get assurance, we will get understanding of the equipment, the devices in this space by creating digital twins, by creating emulated versions of them that we can then test outside of the live hospital network. You know, testing a live system is always risky. You know, you don't push to production directly when you're developing software. We need a dev environment. We need a test environment for the hospital, the technology that we have deployed in our healthcare environments. So if we're emulating these devices, we can start to create a digital twin of the entire hospital, a simulation of the entire hospital that lets us test and make strong claims about the properties of that specific configuration of that facility. Given that whole simulation, finding vulnerabilities, performing automated vulnerability detection becomes, we can bring healthcare sort of in line with other industries and sort of best practices in the traditional compute space, where we're able to scale and parallelize analysis because we have digital twins, because we have virtualized versions of these devices, and use that same technology and logic to then analyze potential fixes. Whether that's thinking about the application of a vendor patch and identifying what systems it changes, or considering a firewall rule, these are just examples, or even potentially more creative options, you know, the application of segmentation or microsegmentation. There are lots of tools that attempt to enable automated segmentation at one level or another of networks. But once again, doing this for the highly sensitive, high availability requiring healthcare environments is an additional set of challenges that we'll need to address. So how will the system work? How will Upgrade ultimately leverage these different technical areas to achieve the goal of a more secure hospital network? So the first step, we'll have TA1 mapping the environment of the hospital. Mapping in healthcare environments can be challenging because of the risks involved with different types of scans. And so we're looking for creative solutions and ideas on how we reason over that environment in a safe way and get the best possible picture of what's actually deployed, what's running, what's talking to what in that environment. Once we have that mapping, we can start to build a simulated version of the hospital network. We can use existing virtualization technology for some of the devices. Others will be able to identify as gaps, specifically, thinking about equipment that may not be emulatable given current platforms like VMware and QEMU don't support right now. There is not currently support for it. Once we've identified those gaps, to augment the incomplete simulated network, we will start creating the emulators of those devices. And here, we're not just looking to have developers create emulators. We're looking to automate portions or the entirety of the process. So thinking about how you consider the artifacts that may be available about a device and its functionality and how that could inform automated creation of a low to moderate fidelity emulator, and then how you refine that, what additional artifacts would be helpful, what inputs, thoughtful use of hardware in the loop, because ultimately the goal is to be able to virtualize, do as much of this without hardware as possible, so that we have that emulated network. Once we have, as that network sort of iteratively improves its fidelity and completeness, we're able to now reason over it and start looking for vulnerabilities, looking for security issues based on both the configuration of individual devices, the network topology. Any of the characteristics captured in the simulation are potentially of interest if they expose the network to danger. And then as we identify those vulnerabilities, testing and staging remediation capabilities there, once again, the simulated environment enables this feedback loop of vulnerability discovery and remediation development that can iterate sort of, where the only limitation is how much compute you have available. And then once that has refined and passed a certain point, it comes back to the vulnerability mitigation platform, and we look at the right ways to deploy that back into the real network. And that deployment would be dictated by the facility itself. We are looking to empower the teams in terms of their capabilities, not take their decision-making away from them, providing more evidence as to the utility, efficacy, lack of interference of any of these remediations, in addition to the data on the severity or potential impact of the vulnerabilities, I think are key components of helping make that decision both informed and also able to be made faster. So to recap, some of the challenges here on the left that map into the TAs in terms of problems. One of the things that I think is worth calling out is the decision support for the hospitals, for the different stakeholder roles that are involved in the decisions that affect patching or modifications to the technology environment. We want to provide high quality evidence as to the impact of, or the likely impact of the application or change, or the application of remediation or change to the environment. And how that looks changes if you are a hospital administrator versus maybe the head of imaging or radiology versus clinical or biomedical engineer versus the IT staff. So, providing people with the information that is both relevant to their decision-making and also speaks to them, is in language that is appropriate for them, but still ultimately comes from the same model, comes from the same understanding of the space. I think could be very, very impactful. And this is about better understanding, enabling us to automate and accelerate actions taken in this space, ultimately yielding more secure healthcare technology and hospital clinical environments. So getting a little bit more into TA1, this is TA1's role faces the most different, I think, roles of person. So this is something that the vulnerability mitigation platform is effectively providing an interface to the existing IT staff, potentially producing artifacts for other roles in the hospital, or providing the IT personnel with those artifacts to sort of route appropriately, and also dealing with the other performers, dealing with the performer technology that will be developed on the program, and the commercial partners that we are hoping to engage that already have good solutions for pieces of this problem. I think if we're able to, CISA's guidance on application of critical vulnerabilities, especially for critical infrastructure, but high severity and then sort of critical severity vulnerabilities, hitting those timelines, hours or days, for application, that's not a low bar. But it's that if we can enable the possibility of that, and then it's up to the facility, it's up to the teams themselves to make the decision. But technology should not be the limiting factor. Manpower should not be the limiting factor when they make that decision. That's really what TA1 is challenges. remove the roadblocks for the team so that they can make if they decide to wait to patch, that's their decision. But that decision should be an informed one, and unrestricted by other kind of technological or labor constraints. So when I think about a strong performer in this space, they're really focused on enabling deployment, installation, reconfiguration. That they're looking at managing devices in a vendor agnostic and even device class agnostic way. The amount of context that we can get from the interfaces that humans use to interact with these devices is considerable. I think we've seen recent advances in technology for creating both kind of context models and also automated or semi-automated reasoning through these state spaces. That's very intriguing. It's daunting, I think, given the complexity and the wide number of vendors and technologies in this space. So definitely a challenge, but I think one worth tackling. Strong TA1 performer should be able to provide visibility into the current state of the environment. And once again, this can leverage existing commercial technology if that's the approach that you think is the best path to solving this problem. When we talk about automation, when we talk about upskilling personnel, I think there's a lot of opportunity for augmentation of existing staff, or even enabling non-IT staff to be an oracle for a process or for a tool where the real world context that human can provide is sufficient, matched with the expert design system that understands the environment or understands how to understand the environment or the devices, and can use that human to ensure that its decisions do not negatively impact the network, do not negatively impact the device. And then another large component here is assessing existing tools. It's very hard for us to tell if we are making progress. We don't understand how the current configuration, how it works in situ, how the specific deployment in the specific environment of our healthcare partners, of these facilities and these teams. We need to be able to understand how long it takes them to do critical tasks, where the pain points are, the tools themselves, if they have kind of blind spots, or if the adaptation from general enterprise use case to healthcare, what has that left unaddressed or underaddressed? What vulnerabilities do they not see, do they not find? And then TA1 performers that are able to bring a hospital or healthcare kind of provider partner to the table initially, and then show that they've started to engage there. That'll be a very promising sign. I know a number of you on the call today are not looking to participate in the program as researchers, you're looking to participate as partners. And so we will also be cultivating and working with you to identify good fits between ultimately the performer base and based on your needs as well. So I'm excited to have those conversations with you, and I really appreciate you folks taking the time, given all the constraints and challenges that you have to deal with, to engage with the program. In the draft solicitation, we described the different flavors of collaboration between the TAs. This is pull out of that table focused on TA1. The one thing to highlight here is, or the thing I'd like to call everyone's attention to, is that TA1 should be able to ingest TA2's emulated devices. There are a number of frameworks for how we emulate the devices, how TA2, best TA2 performers in terms of emulator development and automated development will be TA1 and TA2 will have to work together such that TA1 can incorporate those emulators into their simulation of the hospital environment. Speaking of emulation, TA2. I've talked with a number of medical device manufacturers about how they do internal testing. And it's been very interesting talking to folks that do already do pre-silicon validation and testing using emulated versions of their own devices, and how much value that adds in terms of testing, in terms of their pipeline, both CI/CD for compatibility and support, but also as the evolution of the hardware platform, how that can potentially help. So I think there's promise in making emulation more cost-effective and reducing the amount of specialized developer knowledge required to do that for the different kind of hardware classes in this space. Because we have these sort of high fidelity digital twins and we're able to create a very comprehensive simulated hospital network. I think it opens doors beyond security, but that is the use case that we are focused on in Upgrade. But so I encourage folks that are thinking about TA2 as security as the first step on what a high fidelity complete hospital network simulation could enable generally. And so when I think about TA2 performers, I think about prioritizing what elements of a device or piece of equipment are emulated based on, are they external facing? Are they dealing with sensitive data? Those are the idea that we would begin with like rehosting of select sets of binaries or processes potentially makes sense on the way to dealing with peripherals that may be unknown or require a lot more work to build a model for. I think on that note, tunability from an emulator perspective, that if having a dial, grossly oversimplifying what that entails, but having the ability to sort of tune between fidelity and performance or cost to run, since we're talking about compute, there's a big difference in having a 10x or 100x slowdown, depending on the device, depending on the situation, being able to adjust that. Maybe that's acceptable in some situations, and in others, we'd rather have lower fidelity but be able to run more tests or iterate faster. I strongly encourage folks to consider device agnostic approaches or peripheral agnostic approaches as well. So if you encounter a new device, because the space has so much variation, thinking about this from what artifacts would I need what information would I need about this board to increase my ability to emit an emulator for it. And think about that more generically. That TA2 emulated devices should enable inter-device and inter-application connectivity and interactions. Ultimately, that is more of a TA1 task, but TA2 should consider it as part of the development. And thinking about how fidelity of the emulated device or the specific components fidelity maps to confidence in ensuring continuity of patient care. So making that, I think, more explicit, not less, I think is important. One of the key interactions between TAs here will be between TA2 and TA3, where the expectation is that TA3 will be able to leverage the TA2 developed emulators for vulnerability discovery. TA3 will not block on TA2's emulator development, but there will be interaction between them. I will also say here that some of the medical device manufacturers that on the call today, we have talked. I would encourage performers and manufacturers, if they're interested, we would love to partner with you and enable partnership for device emulation. I think the value of multi-vendor emulated device environments, especially in this space, could be very high, especially when we start thinking maybe beyond just security. And so we're very, very open to having these discussions with you, ensuring that your concerns are addressed, that your interests are protected, but that you're also able to participate in a meaningful way with our performers. So automated vulnerability detection, TA3 and TA4 both have, I think, sound maybe a little generic at the top level, but in this specific case, we're looking to create new vulnerability detection techniques based on how human experts find vulnerabilities. There has been some work done in this space, not a lot, studying hackers, studying vulnerability researchers is itself a challenge. Studying them over the course of analysis of a complex piece of software or hardware is extra hard. But I think if we're able to recruit and work with folks and start building and better understanding the processes that they use, we will be able to automate these processes far more effectively. It's really interesting to look at papers that aren't actually necessarily studying the experts themselves, but that expose sort of accidentally that's the experts' understanding or lack thereof of the thing that they are very good at. So, right, the ability to do something very effectively, but their own model for it is maybe not correct, which I think is interesting generally, but in this space and my own familiarity with it, I find it extra fascinating. So if we're able to build automation based on that knowledge, those models, the goal is to then use that to make vulnerability discovery far more, do it faster, do it more cost effectively, and potentially start generalizing some of these, once again, in a platform agnostic way, in a star agnostic way, I guess, kind of depending on whether it's a vulnerability, a CWE kind of class that you're thinking about, or a platform, or a particular language, thinking about this in a more generalized, unified way. That said, right, for TA3, I see strong performers studying human processes and translating those into better automated techniques. Human in the loop workflows are in scope. Things do not have to be fully automated. Justifying why the value of that manual effort, that I think will be the key for folks that are considering this, that as part of their approach. As we'll talk about in a bit, the metrics, I think you can hit the program metrics with still having some manual effort, but it will be challenging. And then another thing to raise here is no false positives, right? We're not looking for warnings. We are looking for, like, this thing is an excitable, like, vulnerability. This thing is a real risk. And there's a large body of work over the last decade that looks at how you exercise, how you determine if something is an exercisable flaw. Is it reachable? So really encourage folks to think about that when they're thinking about this space. And then even if TA3 is identifying more device-centric flaws, that you're considering the network environment or other connected devices as you perform that reasoning. So thinking about, like, multi-binary kind of interactions, whether they're on the same host or across the network, how you model that, how you reason over that in this space. TA3 and TA4 are going to have a very close relationship. TA3 is not required to fix anything they find. TA4 is not required to find anything, but we do anticipate a very close working relationship between the TA3 and TA4 performers because of that interdependency. And then TA4. So developing or suggesting remediations for discovered flaws. I think creating remediation capabilities that are as specific to the target environment as possible is the goal here. Fit to the specific network, to the specific device configuration as much as possible. And consider how you might, because I think also considering the system as a whole enables you to consider remediation options that might not otherwise be viable. So, suggesting segmentation is great. Implement, like, actually identifying the network interfaces and or management systems for the network and automating the process of resegmenting that, it's better. Reconfiguring a device, like changing an existing configuration option on the device, perfectly reasonable. And so as you reason over these devices, thinking about them more from, like, an application level or thinking about the interfaces, thinking about how the device is used and how it needs to be used as you're considering how to defend it. Number one, I mean, this goes for the entire program, but one of the number one things to keep in mind here is nothing we do as part of the upgrade program will interfere with patient care or negatively impact any patient outcomes. Full stop. That's not an option. And so given that bar, performers across TAs will be working together to ensure that that doesn't happen. So for TA4, without, being able to reason over devices without necessarily recreating or duplicating the effort of the other TAs may be challenging. I encourage you to think about different ways to model the state space of these devices that maybe where you're not duplicating the effort of TA2 if there's not an emulator available. I think there's an interesting space to work there when you think about the configuration space, when you think about different elements of the operating system that don't necessarily require the same level of granularity that emulator development might. So I think that's an interesting space for folks to play at a slightly higher level. And then similar to the other TAs, going for platform agnostic approaches, and then supporting legacy devices. So not TA4 should be able to support a previously unseen device. Now, there may be requirements in terms of context required, the documentation, the artifacts required, but we should not be pre-programming device handling on a per device basis. And then, pick the options that are least invasive, least require the fewest changes to the system that achieve the desired effect. TA4, be working very closely back with TA1, because as TA4 develops remediation capabilities, TA1 may come back and sort of based on feedback from the hospital partners, there'll be a fitting, right, that occurs that where TA1 is responsible for presenting and deploying, and TA4 is responsible for developing. So once again, a dependency to be sure, but I think a manageable one. So when we talk about metrics for success, I think the big ones here have to do with time to a result, whether that's the time to discover a vulnerability, the time to develop an emulator. You know, we're looking for orders of magnitude improvement in these processes that are doable today, but too costly, too time consuming with the way we do them. So that's a big component here. And then thinking about the equipment classes, we're starting with smaller devices. We're starting with devices that are cheaper to acquire, but also very numerous in healthcare IT environments. So they represent, I mean, these 3 devices alone represent more than half of the number of devices deployed across US healthcare facilities. And then in phase 2, moving to devices where they're more complex, they're more expensive. And so the testing equities, the concerns when we think about hardware in the loop, you know, it may be far more achievable to have an infusion pump testing with hardware in the loop than an MRI machine. And so technologies that can scale, that can reduce or remove that requirement are very much interesting. And then just remediation complexity when we think about stateless versus stateful. I think a configuration change, stateless probably, the idea of a stateful proxy that might be doing data sanitization as just an example. I think that's interesting if it's appropriate and effective. Overall timeline for the program, it's a 2-phase program. Phase 1 will be 18 months, phase 2 will be another 18 months. And in phase 1, our goal is to create an increasingly high fidelity simulation of a 50-bed hospital and add as much of the hospital equipment that we can from an emulated or emulators and digital twins of as many devices as possible. And driving us towards that goal will be a series of hackathons that will bring together members from across the program, across the TAs, that will bring stakeholders all into the same room where we spend, you know, the better part of the week hashing out a challenge problem that is related to everyone's existing sort of approaches and work. These have been extremely productive for those of you that have worked like this, especially with a DARPA program. I think these are very kind of uniquely energizing events, and they kind of get us. They really force us to validate the assumptions that we're working under. And I mean, they're also a lot of fun, especially in the post-COVID world. I think on-site work with motivated, smart folks is a good time. That is great. That is the program. Great. So I'm very happy to introduce our next speaker, Brian Mazanek, Deputy Director for the Office of Preparedness at ASPR at HHS.
Great. Thanks, Andrew. I appreciate the opportunity to join you all. What I will speak to will be far less interesting, I think, than what Andrew just walked through. We're really excited within ASPR and across the HHS and the great work ARPA-H is doing to help us advance our mission to help ensure the cybersecurity and cyber resiliency of the healthcare and public health ecosystem. So I'm going to just give a little bit of context where I think all of the good work ARPA-H is doing falls in. Just from the broader departmental overview. So I have a few slides and I'll kind of move through them fairly quickly, but just again, want to give you all a framing for the broader effort in which this sits. So if we can go to the next slide. So just briefly, and ASPR leads in this role, but it's really the department writ large. For those who aren't familiar, there are 16 critical infrastructure sectors that have been identified in the United States that have sector risk management agencies, or SRMAs, responsible for working in partnership with the sector to ensure that threats, it's all hazards responsibility, not just cyber, but that threats are addressed, that intelligence and information is shared effectively across the sector, that there's an incident response mechanism in place, that there's preparedness from an emergency preparedness perspective. Just wanted to make sure everyone understood that from a broad contextual perspective. HHS serves as the sector risk management agency for the healthcare and public health sector. And within HHS, ASPR has been identified as the SRMA lead. And ASPR is the Administration for Strategic Preparedness and Response. We're kind of the emergency response arm of the department. We have a I think, a much better recognized mission for responding with medical support in the context of a hurricane that takes out a hospital in Florida. We can bring with the National Disaster Medical System, sort of a pop-up hospital. We also have a significant effort to develop and stockpile medical countermeasures for pandemics, but we also have this probably less well-recognized mission to support the healthcare and public health sector from a risk management perspective, and cyber has been a huge part of that, just given the ransomware activity that we see against hospitals and other elements of the healthcare ecosystem. Obviously, the Change Healthcare attack in February, and more recently, the Ascension healthcare attack are really powerful illustrations of the threat that the healthcare ecosystem faces for a number of reasons that some of ARPA-H's solutions are intended to address, but it is unfortunately an attractive target. And depending on what data source you slice, it is either the number one or certainly top 2 or 3 of the critical infrastructure sectors that are getting hit by ransomware attacks. And as the Sector Risk Management Agency, our focus is most robustly centered around protecting patient health and safety. So we want to make sure that medical care can continue to be provided with, and it is not in jeopardy as hospitals and others navigate these ransomware attacks. So the slide outlines the 6 statutory responsibilities that we have as an SRMA. I think a number of the things that ARPA-H is doing in partnership with the private sector and academia will be useful, ultimately develop useful tools and things that we as the SRMA can help bring to the sector, help the sector adopt, and also in some instances actually procure ourselves as sort of the end user from an incident response perspective or otherwise. Next slide, please. I just want to foot stomp our role as that sector risk management agency is really built upon a robust private public partnership. We have a sector coordinating council, and encourage those of you who are from private industry here, if you're interested, if you're not yet plugged in, to get engaged in the sector coordinating council, which has a really subordinate kind of cyber group that does a lot of great work with us and informs a lot of where we focus our energy. So that's really all I wanted to foot stomp here. Next slide, please. And this is really just to illustrate, and this is my last one, on just framing that role that the department has as the risk management agency. That while ASPR serves as sort of the quarterback or the coordinator of the SRMA function, it is very much a team effort across HHS. You can see ARPA-H is on there. Obviously, that's the main focus today, but there are a number of other key elements of the department that play a role in supporting the sector, particularly from a cyber perspective. So this slide, I know, it's pretty much impossible to read all the text there, but what I'm about to talk about is a document that actually has this full version on it if you want to go and pull up, and I'll have a link at the end too that you can get to it, but if you want to read the actual text, but it describes the cyber focused role that each of these organizations have as part of the SRMA team. And this is really not an all-inclusive list too. I think there are other elements of the department that also play in that just aren't depicted here. So we'll have to continue to iterate on that. And then of course, on the left side there, you can see the sector partnership I mentioned with private industry, but we also have a really strong relationship with CISA, the Cybersecurity and Infrastructure Security Agency, which we work with every day to support the sector, particularly from a cyber perspective, but also all hazards. And then the FBI, who we work with very, very closely on that incident response lane. They have the criminal lead in responding to ransomware activity, but we work very closely together. We actually have HHS personnel permanently embedded within some of the FBI's joint task forces that are focused on cyber threats. So we are lashed together at the hip. Next slide, please. And actually, you can skip ahead 2 slides. Next one. So here, just to frame everything really in the department's broader vision. So we've been concerned for some time about the rising severity, sophistication, frequency of malicious cyber activity on the healthcare sector. We worked very closely with those private sector partners I mentioned previously. Throughout last year, we did a landscape analysis, did a number of things that I think are also informing some of what ARPA-H is doing now, but they culminated for the department overall with the development of a concept paper or strategy that we rolled out in December of last year. If you just Google HHS cyber strategy, you'll probably find it. It's a simple 6-page document concept paper that outlines these 4 pillars you see on the slide. I'll talk to each of them really briefly. They're not really particularly complicated or profound concepts, but we think in their simplicity and focus, they really are the core things that are guiding the department's efforts overall to help the sector improve its cybersecurity and cyber resiliency. So the first one, and I'll go into this one a little bit more in a moment, is the fact we heard a lot that there's confusion in the sector about which best practices to follow. What are the most high impact practices from a cybersecurity perspective for healthcare in particular? There's CISA's cross-sector cybersecurity performance goals. There's the NIST cybersecurity framework. We have previously and continue to find it as a useful tool published within HHS, the HICCUP, the Health Industry Cybersecurity Practices. A lot of guidance, confusion, especially for those less well-resourced entities in the ecosystem that maybe the IT specialist or CISO it's their third or fourth job. They've got a lot of other responsibilities. They don't have time to sort through that. So we recognize the need for more simplicity and focus to identify the high impact practices for the sector. So that's these voluntary healthcare specific CPGs. I'll talk a little more about them in a moment. The next one was just bringing more resources and incentives to the sector to help implement these best practices to do more. We think that this is a key part of the equation. This is some of what ARPA-H is doing, is really developing through their efforts, tools, resources, things that we can then drive into the sector to help improve its cyber posture, especially again for those really less well-resourced entities that have razor tight margins, just don't have the infrastructure to deal with these threats. So we want to meet them where they're at and bring them resources. We're also looking at other tools the department has to do this. Well, the big one in the president's budget this year was a $1.3 billion request for a program that the Centers for Medicaid and Medicare would execute to really drive these incentives and resources into the sector. But we're looking at other tools like the Hospital Preparedness Program, HPP, that ASPR has. We worked in some cyber elements there, just as an example. The third pillar is focused on enforcement and accountability. We recognize, in addition to bringing more resources, simplicity and focus on the right high impact practices to implement, there also needs to be an accountability element. This is reflected, I think, in what the department is doing now to update the HIPAA security rule, but also other efforts underway. Now, we can't go into a lot of detail today here on to use other levers the department may have to push from an accountability perspective. And that's consistent, I would note, with the national cyber strategy that President Biden released, which called for each of the critical infrastructure sectors to have mandatory minimum standards. So we're working towards that goal outlined in the president's national cyber strategy. And then finally, the fourth pillar, and just from where I sit, the one that's most near and dear to my heart is the ASPR really building out as a one-stop shop for cybersecurity. And I joke there, but I mean, it's not really, ASPR will be the one-stop shop, kind of manage the front door for the department, but it is still going to be very much a team effort, with ARPA-H and many others playing a critical role. But we've heard that it's too confusing for entities to figure out where do you go, who do you talk to within HHS to get different things. The healthcare sector shouldn't have to worry about that. We're building out kind of a simple HHS cyber brand, single front door. ASPR will manage that, but that should be invisible to the sector. It'll be just HHS cyber. This is where you go, and we can plug you into the whole tapestry of resources we bring to the table. Another big part of this is building out our incident response capability, which ASPR will also manage, given our kind of emergency response ethos and capabilities. But that's something that we know we need to do more of, and have been working diligently to build out more incident response capabilities, more supports we can bring to an entity when they're victimized by a ransomware attack. So in a quick nutshell, that's the 4 pillars that are really guiding the department's efforts. Next slide, please. I won't belabor this much, but I did want to just speak a little more detail on the CPGs that I mentioned, that first pillar. We published this strategy in December. In late January, we published the first iteration of the CPGs. You can see here what they're intended to do. I mentioned the confusion that exists within the sector. This is intended to really simplify that, provide a robust and clear framework that entities in the sector can follow to improve their cybersecurity and cyber resiliency. Next slide, please. They're in 2 buckets. So there's essential and enhanced CPGs, 10 in each. Many of the enhanced are just simply more robust versions of the essential goal. So one is focused on the essential, is focused on incident preparedness and response and having an incident response plan. Again, not a deeply profound concept, but still very, very important. The enhanced version has you exercising that plan, iterating based on those exercises. So just a little more robust version. So there's things here too that we've unfortunately seen in the change attack that's been discussed in the Ascension attack, simple stuff like multi-factor authentication. So really, these are the 10 most high impact practices we believe to implement. We are going to continue to iterate on these. We've already heard a lot of feedback. Welcome your feedback on them. But I think some of the great work ARPA-H is supporting will be useful to helping the sector implement more robustly some of these CPGs. So wanted to provide that as context. And next slide, please. And this is just to emphasize too that we did, while I mentioned this is intended to simplify things, we don't want to add to the confusion. We also recognize a lot of folks have already done a lot of work to map against the NIST, CSF, other frameworks. So when you do go look at the CPGs, you'll see we were very, very intentional to do a robust mapping backwards and forwards in all directions so you can see where the connections are if you've already put a lot of effort into a different framework, so you can just see how they're connected. So wanted to mention that as well. And the next and last slide for me, and I know I'm just kind of covering 30,000 foot here to give you this context, but the last slide has a website. So next slide, please. So this hphcyber.hhs.gov, we built this fairly quickly, so it's not incredibly sophisticated, but it's our new cybersecurity gateway. We're going to be evolving the domain, I think, to be just HHS Cyber, because most folks don't know what HPH is, even though that's our sector's acronym. So we're going to keep it as simple as possible. But we built this concurrent with the launch of the CPGs in January. We're going to iterate on this and make this kind of that front door I mentioned. So this is you're going to see a lot of functionality come into this site, and it's going to be the place where you can go to find what you need from the department. It may link you to other sites and other places, but this should be a good comprehensive front door for everyone. I'd also note that email address too. This is our 24/7. We manage this HHS Cyber inbox. We use it for incident response. Again, that's that 24/7 piece. So it does get a lot of traffic when we're dealing with a significant incident, but it's also just a general inbox. If you have questions about anything I talked about, what the department's doing, want to connect with someone somewhere in the department, don't know where to start, but just have a general question, please don't hesitate to reach out. We welcome your feedback and certainly want to be as supportive as we can to the sector as it tries to improve its cyber posture. So I'll stop there. Hopefully that gives you a good orientation of where the department's at and what we're doing. And I'll hand it back to Andrew.
Thank you so much, Brian. Really appreciate it. Thank you for the overview, and we're super excited it's been exciting to work with you so far, and exciting to continue working. Now we have Marissa Maloney from ARPA-H, who is going to go into some of the acquisition details, both for Upgrade and just in general working with ARPA-H might be new for a lot of folks here. Marissa.
Thanks, Andrew. Hi, my name is Marissa Maloney, as Andrew just introduced. I'm one of the agreements officers within the Business Innovation Division, known as BID, within ARPA-H. I primarily support the Resilient Systems Office, RSO, which is where the Upgrade program resides. BID is ARPA-H's internal contracting shop. I know that some of you might be new to working with the federal government or new to submitting to ARPA-H solicitations. So I'm going to quickly explain who I am, how I'm involved in the solicitation and acquisition process. Agreements officers work with the ARPA-H PMs once they onboard to help with the acquisition strategy and approach as they build their new programs. We then aid in the development of the solicitation, approaching things from a business and acquisition standpoint, and then during the solicitation process with solution summaries and proposals, with the evaluation of submitted proposals, and then once selections are made with the negotiation of those awards. After award, we are the main POC between the PM and the performer regarding changes in scope and any and all required modifications to that awarded agreement. Again, like I said, I know there likely are some folks who are new to working with the federal government. If you're not new, you may be unfamiliar with ARPA-H or unfamiliar with other transaction agreements. What I will cover today will be an overview of the upgrade modular announcement at the 10,000 foot level to include the master announcement instruction, the MAI. And I'll also touch upon key facts such as the timeline, pertinent details from the modular announcement, and what to expect as we move forward after Proposer Day. Okay, let's move on to the next slide. I love to start with this slide. This is my Proposers Day disclaimer. Overall, the goals and objectives of Proposer Day are to introduce the program vision to the research community, clarify program objectives and milestones, encourage and promote networking and teaming, and to solicit questions and feedback on the program. During the upgrade Proposer Day and during the draft solicitation period, a lot of information is going to be made available to potential proposers to help clarify goals and objectives, to include proposal preparation instructions for the solution summary and proposal submission stages. However, only the information contained within that final modular announcement and the master announcement instruction, the MAI, is what counts. Proposals are only evaluated in accordance with the instructions contained within the MAI and in accordance with the technical objectives stipulated in that final upgrade modular announcement. While we're not anticipating significant changes from the draft to the final modular announcement, I do want to drive home the importance of first reading that draft and also reading that final modular announcement in its entirety, as there will not be a crosswalk to denote what has changed, if anything, between the draft and the final. Lastly, the dates that you see in the draft are anticipated dates based on when we expect to post the final modular announcement. So again, please read that final modular announcement and use the dates in the final modular announcement for your guideposts of when things are due. Also, please make sure you're checking the Q&A posted to our team webpage frequently. We've already posted a bunch of Q&As and we will continue to update after Proposer Day. These Q&As are going to be a valuable resource in the interim while we work to get that final solicitation posted. Next slide. Currently, ARPA-H, in particular RSO, has posted 4 modular announcements on SAM.gov that hopefully you have seen. Those have been BDF, React, Adapt, Care, and now Upgrade. Upgrade is the 5th. The first announcement you will need to open and read in its entirety is the Master Announcement Instruction, the MAI. The MAI is going to be your manual, which has all the overarching instructions and details that you'll need to use as you apply to the upgrade modular announcement. The MAI, though, is not what you're proposing to. So it is not, if you're looking at that MAI document, there's going to be no technical descriptions of a project or program. It's just your overarching manual guide or reference to help successfully propose to each modular announcement that we issue off of the MAI. So the second document that you'll need, obviously, is the upgrade modular announcement. Within the upgrade modular announcement, you'll find the background information on the program, the goals, the technical areas, information on intellectual property, program deliverables, etc. Most of what you've just heard Andrew give an overview on. Solution summary and proposal content and format and guidelines will be provided in the final modular announcement via attachment Appendix A and Attachment 1. All potential proposers need to have that MAI and the modular announcement up as you write your solution summary and proposal responses. Next slide, please. Next, we're going to touch upon the upgrade modular announcement basics. As you see in the first quadrant, I want to really stress this, that upgrade is only looking to award other transaction agreements. You may be wondering what those are, and I will touch upon those in the next couple of slides. So again, if you're proposing to upgrade, please make sure you're not proposing a FAR-based contract or grant or cooperative agreement, as we will only be awarding OTs. Next, as you've probably seen in the modular announcement, multiple awards are anticipated across TAs, and we're doing that to foster diversity of solutions. Please note that you may submit a solution summary and or proposal which addresses any of the TAs or a combination of TA 1, 2, 3, or 4. However, what's important to note is if you're proposing to more than one TA, do not do so in multiple solution summary or proposal submissions. Please make sure you're doing that in one submission. The bottom left-hand quadrant shows the upgrade timeline, which is tracking to the draft modular announcement. I will note that there is one inaccuracy in the solution summary due date. That should say July 11th. But the key takeaway here is what I just stated in the previous slide, is to check the final modular announcement for all finalized timelines and submission due dates. All of these dates are based on us notionally posting the final upgrade solicitation in the end of June, which is what we're still tracking to. In the right-hand lower quadrant, you see the technical areas in the program timeline. I'm not going to go into detail on the TAs as Andrew just did, but just noting that, like I said, there's 4. You can propose to one or several of them, any combination. But the key takeaway here is that each TA spans both a base and option period. If you're interested, again, like I said, in more than one TA, do not do so in multiple solution summaries or proposal submissions, do so in one. Also, I will note all TA 2, 3, and 4 performers are expected to collaborate with all TA 1 performers. So just be mindful of the collaboration requirements that are laid out in the modular announcement. And lastly, as you see here, there's a base period and an option period. So if you're not familiar with options, I'm just going to touch upon what they are. So options are negotiated upfront from a technical and test perspective and also from a cost perspective. They're included in our awarded agreements, but they will not be turned on, which just means your base agreement will be for that base period. It'll reference the option, the tasks from a task perspective and a cost perspective. And then if we will review your progress against the metrics in the modular announcement, in the upgrade modular announcement, and then the decision will be made to exercise your option. And that is, the exercise of options is based on the government's sole discretion. And if you get your option exercised, your agreement will be modified to capture that increase in dollar value and term. Next slide. This slide represents some of the unique characteristics of the MAI and the upgrade modular announcement. First, we have established modular categories to help the government convey the level of effort we're anticipating. With that said, the upgrade announcement is anticipating responses at the bit, byte, kilo, mega, and gig levels. The inclusion of this many categories is to cover the varying combination of proposals that we may receive. So if someone's proposing to one, some, or all the TAs. The intent behind the modular categories is to convey the differences in scope and cost. So more exploratory work, or say you're proposing in one TA, you'll likely propose at the lower end of the modular category, the lower dollar value. And if you're proposing for TAs, likely propose at one of the larger modular categories. I also want to highlight that the dollar values should be used as a guide. I want to note specifically that there's page restrictions with each of these categories that we've implemented to just ensure that we're getting clear and concise technical solutions. Ultimately, please ensure that the cost point selected is commensurate with the scale and complexity of the proposed approach. Of significance is, and something that I want to note is, proposals that simply align a proposed budget to the modular category ceiling value are strongly discouraged. Additionally, as you see in the slide, we have stage submissions. So the first submission is for, the first stage is for the volume 1 submission only. As shown here, you're going to submit a basis of estimate rather than a full price and cost proposal. If your technical solution is selected, you'll receive a notification of selection, and we will request the stage 2, volume 2 proposals at that time, and we'll provide the templates. Lastly, the modular announcement will have an OT bundle of attachments. That OT bundle will be attachment 1, and it'll be provided with the final modular announcement. Please make sure you're using the templates that are included therein, as it'll greatly speed up the government's review of your submission. So the next slide, we're going to touch upon what are other transaction agreements. Very simply, OTs are not bar-based procurement contracts, grants, cooperative agreements, or cooperative research and development agreements, CRADAs. ARPA-H has the authority to enter into and award OTs when the use of such authority is essential to promoting the success of the project. Given the mission of our agency and a lot of what we will be doing under our research programs will align with the use of the other transaction agreement, with the exception being that basic exploratory fundamental research, which tends to align or be best suited for assistance. So what are OTs? OTs are flexible arrangements that allow for free-flowing negotiations. They're not subject to FAR or applicable grant and cooperative agreement regulations. The clauses or articles in the other transaction agreements, awards, are negotiated between the awardee and the government. So OTs really are blank sheet negotiations, which is the exact opposite of procurement contracts or assistant instruments, where the regulations really dictate what must be included and where there's little wiggle room to negotiate. Furthermore, OTs are not subject to the onerous regulations that are associated with doing business with the government. So for instance, cost accounting standards. Overall, OTs really provide that flexibility necessary to adopt and incorporate business practices that reflect commercial industry standards and best practices into our resulting award instruments. Next slide. I talked about some of this in the previous slide, but some of the pros of using the other transaction agreement are noted here. Most notable are that we're not bound by the FAR or any of the assistant regulations, the HHS supplement to the FAR, and we're also able to invoke more commercial negotiation practices, especially for intellectual property, because we're not bound by BIDOL. It allows for a streamlined award process, but that can be a bit ambiguous, and that's really meant to be. OTs can be as streamlined or as rigid as we make it. So honestly, the ability to streamline really is dependent upon the level of details that need to be negotiated between the parties. So when we send that selection letter after the stage submission, we'll also send the model OT, and that'll be your opportunity to review the terms and conditions and provide any suggested edits. And it's really a best practice to have everyone associated with the program, or anyone who's going to be looking at that OT, really involved at that first step, so that the goals and objectives of the program are easily understood, as that will really help streamline the process. As if the goals and objectives and the intent behind the program is understood by everyone, it'll help kind of streamline those red lines. So if you have lawyers involved, they're not kind of throwing in everything in the kitchen sink, and it just kind of draws out the negotiation process. So I really recommend having everyone kind of involved from day one to kind of, drive down the amount of time that it'll take us to negotiate. And with that being said, one of the only cons that I've really seen is that due to everything being negotiable, it really requires negotiation by sophisticated parties. And there's some hesitation by, say, startup businesses or people who just have never, had experience with OTs, and their reliance is on the acquisition regulations associated with the FAR and assistance instruments. That's just where they feel most comfortable. I will say that we work together. We're equal partners in this. So we really try to understand what the issues you are trying to mitigate by your red lines. And we work to get to that middle ground to achieve, what's good for both parties. Next slide. Next, we're just going to talk about the process overview of what to expect after Proposer Day. So like I said earlier, we're working to get that final upgrade modular announcement out on the streets. It'll be posted to sam.gov with links on our team webpage. So the first thing that'll be due is the solution summary. Solution summaries provide a synopsis of the proposed approach from a technical and budgetary perspective. They're strongly encouraged in advance of a full proposal, as they help prevent potentially out of scope proposal. It's a way to get some feedback on your proposed technical approach, but they're not required. And the government will reply with feedback, either encouraging or discouraging a full proposal. But what's of note is that you can submit a proposal regardless of the feedback received. After you receive that feedback from the government, we will not talk about the solution summaries or the feedback provided. There's going to be no informal calls. Working with or the best way to get a hold of the government will be through the Q&A process. I will note, please use the templates that will be provided within the final modular announcement as you prepare your solution summary. And please only submit to the Solutions app. Do not submit to the Upgrade Team inbox or any other method. Please only submit through the Solutions portal. Next, proposals. So like I said, you can submit a proposal regardless of the feedback received to your solution summary. You can submit a proposal even if you did not submit a solution summary. The final modular announcement will include the template docs. Proposal submissions should be done in accordance with the stage 1 submission instructions that are in the modular announcement. Please, again, make sure you're submitting your proposals only to the solutions portal, not anywhere else. Do not submit to ECPS. Please do not submit to the upgrade team inbox. Please follow the page restrictions associated with the modular category that you select. Please do not select a larger module category to gain more pages to reiterate your solution in different ways. Next, moving on to the evaluation. So ARPA-H conducts scientific reviews, which are merit-based. Proposals are evaluated on individual merit and relevance as they relate to the stated goals and objectives rather than against one another. Overall, we're looking for the best of the best, which may not be the cheapest. Proposals are not compared against one another as they're not submitted or prepared against a common scope document. So the government will be reviewing all conforming proposals against the evaluation criteria noted in the MAI. Please note that the stage 1 submissions will only be evaluated against criteria 1 through 3, which I'll touch upon in the next slide. And then the stage 2 submissions will only be evaluated against criteria 4. Please note you'll only be asked to submit your stage 2 submission after we have sent you that selection letter based on your technical approach. And again, just driving home the fact that you really need to have that MAI, master announcement instruction, and the modular announcement up and use those 2 documents together as you work to prepare your solution summary and your proposal submission. So I'm just going to quickly touch upon these. These are the evaluation criteria that are stated in the MAI. Again, this is a staged submission process. And like I just said, evaluation criteria 1, 2, and then if you go to the next slide, 3 will be based on we'll be looking at those 3 evaluation criteria and your stage 1 submission. And then criteria 4 will be if you are asked to submit, you get that selection letter, and then you'll be requested to submit your stage 2 submission, and we'll look at that against evaluation criteria 4. This is my last slide, and this is just some final guidance and suggestions. The final MAI and upgrade modular announcement, as I stated, will be posted to sam.gov. We will have links to all of our postings on SAM on our team webpage. So please just get in the habit of checking the upgrade team webpage. That's where you'll find all of the official documents. That's where you'll find our teaming profile. Also, there'll be links to our Q&As there as well. Make sure that you are looking right before submission to make sure that there's no amendments, because if there's any amendments to the upgrade modular announcement or the MAI, we'll again post them on SAM and then have links to it on the team page. Just a reminder to thoroughly read and use the MAI and modular announcement in the development of your proposal. I know I sound like a broken record, but you'd be surprised at how many people do not. If your proposal is not conforming to those requirements, the government will not be able to evaluate your proposal, and it will not be, as part of the review process, it will not continue on in that evaluation review process. And that's just not where anyone would like to be. Again, make sure you're using the templates that are being provided. They'll greatly speed up the government's review of your proposal submission. And then on the right-hand side, just make sure you're tracking to the upgrade webpage. And there's links to those, the team webpage, and then the submissions and Q&A portal here. Thank you. And then if you have any questions, please put them in the chat or submit to the Q&A portal. Thanks.
Thank you so much for that, Marissa. Much appreciated. So now we're going to move into questions and answers that have been submitted and that the team has reviewed and kind of produced responses for. The Q&A process will continue throughout the solicitation's lifetime. So I encourage everyone to, if you have a question, I know a lot of questions have been submitted in chat today, but please continue to submit questions and check the FAQ site. We will be updating it as frequently as we can, just provide guidance and clarification wherever it's needed. So some select questions that we flagged here. So will the Proposers Day slides and will this talk be posted online? Yes, this will be available for review on the upgrade program page soon. Is a solution summary required? No. As Marissa just said, you don't have to submit a solution summary. I would strongly encourage everyone to submit solution summaries, especially the more creative you're getting with your solution, the more I think it would be helpful for you to submit that solution summary. It helps us think about the problem space differently and maybe see it the way that you see it, but also helps provide you feedback because proposal authorship is a much larger lift. Who is allowed to submit a solution summary or a full proposal? In the MAI, it says that all responsible sources capable of satisfying the government's needs may submit a proposal to a module announcement. Specifically, universities, nonprofit organizations, small businesses, and other than small businesses are eligible and encouraged to propose to module announcements. There are additional details there for FFRDCs and other government entities. And I'll foot stomp teaming here. Please encourage folks to think about groups that you would consider teaming with, especially if they have a different kind of focus, specialty, or different expertise than what you have in-house. Interdisciplinary research is a superpower when you make it work, I think. What is the difference between a solution summary and a proposal? Solution summary is going to be shorter and provide a synopsis of the proposed approach, less detailed. Give us your strategy, give us key elements of the proposal, and show us why you think that approach will achieve the program goals for the TAs that you're addressing. There will be specific guidance and content and formatting provided as part of the final solicitation. And then a proposal is a much longer, more detailed version of your approach, which will have different guidance and templating for you to follow. Can an organization submit multiple proposals? And can an organization be part of multiple teams that submit multiple proposals? Yes. Organizations may be part of multiple teams on multiple proposals. There are no limits, but we request that you consider the most effective way for you to provide your expertise to the program and the TAs that you're interested in addressing. How will proposals be evaluated? The evaluation criteria are set forth in the MAI, and we will be evaluating all proposals based on those described criteria. Who will own any intellectual property generated for the program? So we want to emphasize the creation and encourage people to leverage open source technology when possible. IP rights asserted by proposers are strongly aligned to be, or strongly encouraged to align with open source regimes. IP will be part of the negotiations between proposers and ARPA-H. We want to ensure that IP restrictions do not impede the upgrade solutions from being applied, from breakthrough technologies being developed, and from limiting who and how frequently folks can benefit from them. So this will be a discussion, and just please consider how your IP requirements and your preferences will impact collaboration and transition. Is teaming required? Will the program manager or will the ARPA-H team assist in suggesting teaming? Teaming is not required, not at all. We suggest that you seek out the strongest possible team members for each of the TAs if you are looking to team. We do have a teaming page that many of you have already signed up on that will enable prospective performers to share information about what they're interested in doing on the program, and then potentially contact other interested parties for teaming. But we will not suggest or direct those teaming relationships. This is a long question, but in the draft solicitation, we state that proposers may submit a single proposal that addresses any TA singly or any combination of TAs 1 through 4. Proposers should not submit multiple proposers if proposing to more than one TA. The question is, just proposers here refer to teams, individuals, organizations. As previously stated, proposers refers to proposed teams organized by a prime proposer. If the proposing team is interested in proposing more than one TA, then there should be one proposal submission for that team. Organizations can be on multiple teams, and the same team can submit more than one proposal if the solutions are separate and distinct. I hope that clarifies that question. Would analysis of an ongoing attack, so detecting an attack, an exercise vulnerability already being exploited, or to discover vulnerabilities that an attacker may be planning to exploit after pivoting from an already compromised system, be in scope for this TA? And in this case, this is referring to TA3. So in general, discovery and remediation of vulnerabilities, devices, and systems in hospitals is in scope for upgrade. However, live analysis of an ongoing attack is not in scope. I think that's interesting work, but it's not in scope for upgrade. Will upgrade, specifically TA1, the vulnerability mitigation platform, be made available to non-hospitals, like other organizations in the healthcare ecosystem or providers? Our goal for this program is to secure the unique and complex hospital networks that contain varied devices, traditional IT and OT assets. Hospitals are the focus, but knowledge gathered through this research analyzing these complex systems will likely be beneficial and applicable across other industries and other types of facilities, both inside and outside of healthcare. Yes, that's questions. Thank you everyone for attending today. Really appreciate your time and attention. As I said before, please consider signing up on the teaming page if you haven't already. Please, as you think of questions, submit them to the FAQ, check the FAQ for updates regularly. And if you are considering submitting a proposal, please submit a solution summary. We're really looking forward to seeing the ideas that folks have in mid-July as gearing us up for final full proposal evaluation in the fall. Yeah, thank you again, everyone, and have a lovely day.